the lesion is, so that you will be able to see the layers, and then you can follow those layers and see whether that's covering the entire lesion, which means that, you know, and the key to me is the fourth layer, because that you
Thick
can
layer.
see always. It's a
Thick black.
muscular
Thick
black layer,
black.
and that is also the most important one, because जितनी staging होती है वो भी इसी के हिसाब से होती है, so that actually is the easiest and the
linear will so it's very simple thing is make a saline lab next to it and it makes it a lot easier क्योंकि आपने saline lab बना दिया ना needle से उस next we do it very often जब time तो बहुत shortage होती है ना
so this is just for
finding out the lesion
just finding out the layer of the lesion.
No, just finding the lesion on the linear because linear आप कई दफा lesion नहीं होता ना you've got a very short push span. So what you do under endoscopy?
Okay, so you lift the lesion up.
No, not lesion away because you would then destroy.
नहीं समझ नहीं आई कि बात देखो ना चीज़ है कि ये lesion है.
Supposing this is the lesion, what would you do?
You are struggling to find the lesion on. So what you do, you come slightly back and right here, not in the base of it, right here next to it, you form a saline band, and that will allow you to find the lesion. Then next.
If you can't find the lesion,
if you can't find the lesion,
okay, I understand. But we've never done that. To be honest.
Okay, वैसे the lesion is right. So what we'll do is that we place it down, right?
And I mean, you know, and you have a balloon in your linear scope. I mean, we always go with a balloon. Always. So if I want to use it, fine. If I don't, that's fine. But if I've got a subcutaneous or submucosal lesion, then I will always have the balloon because you just take the balloon and you put the balloon there and you know where to see and but I've never done that.
एक और बात है कि generally the kind of subepithelial lesions that we come across, other than these small lesions, जो कि पहले आती पता था कि कोई इनके consequence, mostly they are 3 to 4 centimeter. हमारे पास क्यों आएंगे? Either at the time of endoscopy or they're going to come into our attention through the CT scan. अगर CT scan है तो the lesions are generally 2 centimeter, 3 centimeter plus. They are clearly visible और जैसे ही आप EUS रखते हैं तो EUS पे आपको फट से नजर आ जाता है. Any lesion less than 1 centimeter is in any case of not much of clinical significance. तो उसमें special sequence तो हाँ ये है कि schwannoma होगा ये इस तरह का जिस granular cell tumor जिनकी कोई potential malignancy का कोई है prospect तो कितना frequently they are 1 in 100,000 cases, much less common यही है.
Most common are the two that you mentioned after
Yeah.
esophagus, leiomyoma, stomach, chest, pancreatic crest है भी तो क्या करेंगे?
लाइपोमा तो देख के खुश होंगे बस इससे ज़्यादा कुछ नहीं करना हमने. नहीं बहुत अच्छा बंदा खुश होता है देख के ना इतना ब्राइट एक्रोजेनिक आपके तो वाह लाइपोमा.
The problem I have is when you've got a lesion in the colon, a polyp or which you need to obviously see layers wise there with the side view it becomes, especially like you said, it's chota also because it's significant you want to look at. But otherwise, generally speaking, totally agree with upper GI तो.
हाँ upper GI में generally कोई इतना issue नहीं होता. Leiomyosarcoma देखिए it will be ill defined and it will be arising from the thick black layer और साथ उसके leiomyosarcoma या liposarcoma. देखिए पहली बात है liposarcoma is extremely rare. I've never seen that. और दूसरी बात है कि यही हम कह सकते हैं कि it has to be poorly circumscribed, well defined नहीं होगा.
So very heterogeneous. Very heterogeneous. But it's
Any questions on submucosal lesions? No?
चलो great, thank you. Carcinoid generally layer 2, layer 4 बहुत कम. मैंने कितने देखे होंगे? Maybe 3 or 4. और वो भी ड्यूरल कैप में, जनरली ड्यूरल कैप में. हाँ जो मिलते हैं तो ड्यूटल कैप पे मिलते हैं। हाँ जी, आपका आ जाओ, आओ जी, सिखाओ सानू की होंदी है अपना पैंक्रेटिक ट्यूमर्स। ये बहुत सिंपल है, ये यहाँ से
सीटी का नेक्स्ट स्लाइड पे आप ऐसे ही
हाँ राइट, मॉनिटर पे जैसे बैठते हैं। सो okay, so I think everyone here knows about the anatomy of pancreas, so I don't need to go into any detail of this. Okay, so it's written. Okay, I'm going to skip this slide first. So, coming straight to the imaging modalities for the pancreas, we have plain radiographs, but it doesn't have much significance other than we can see few specks of calcification in case of chronic calcific pancreatitis, or yes, if we have a soft tissue bulge, we can, especially in the duodenal sweep, and if we are getting the bowel gas shadows, we can say that there is a pancreatic, might be a pancreatic mass here. Otherwise, radiograph is not of much help to us. We have the initial modality of choice as ultrasound, but still, since it is very much operator dependent, we are not happy with ultrasound sensitivity and specificity until and unless it's very obvious pathology in the pancreas, because when we are doing ultrasound transabdominally, most of the times pancreas is being obscured by the bowel gas shadows, and we do write that in the report because while sitting in the OPD we don't have much time to do all the maneuvers to see the pancreas. There are like 4 to 5 maneuvers which can help us to see pancreas on transabdominal ultrasound, but since we are short of time and OPD list, so we don't go for that. CT is the modality of choice for pancreas, whether it's acute pancreatitis, chronic pancreatitis, or any other pancreatic lesion. MRI does help, but in case when we are lost in CT, especially in periampullary tumors, and MRCP is the key for pancreas if we are interested in doing MRI. And even in MRCP, what slices should we order? We order usually T2 weighted sequences, heavily weighted T2 sequences in thick slab, so that we can see very nicely the biliary tree and the branches at CBD in pancreatic duct towards the ampulla. So the nutshell is MDCT is the gold standard for pancreatic imaging. So this is the normal ultrasonic view of pancreas. We actually place the probe in the epigastric region, and we just give it a tilt 45 degrees towards the feet of the patient to visualize the pancreas. So in different patients, pancreas gives us different ecotexture. Like we were discussing yesterday as well, that here we see hypoechoic pancreas. It's, can you, all right, here. So we have to identify the loop of pancreas here. So in fat patients, usually we see hyperechoic pancreas, but in our population, most of the times we are looking at it as a comma-shaped hypoechoic structure, and underneath we can, before I think I should be describing this, I should tell you that when we are looking at the screen, this is the right of the patient here, and this is the left of the patient, this is anterior view, and this is the posterior. So we are having a spinal shadow here, this is the vertebral body, and this is the interior of the patient, this is the right, and this is the left. I think you guys, while you are doing EUS, this is the left of the, this is your left and this is your right, right? But here in ultrasound, we see this is the right of the patient and this is the left. And this is the splenic vein coming from the spleen. And here, this is the portosplenic confluence. This is SMV, and this is the portal vein going towards the hilum of the liver. So, what about CT? As I told you that this is the gold standard for all pancreatic pathologies. It may detect complication rather very nicely, helps in staging the tumor. Now, this is very important. When you have a patient who see a pancreas, you want to know the stage of the tumor. Why? Because if you understage the tumor, right, and it has already spread, you are going to unnecessarily do laparotomy on that patient. And if we understage the tumor, it's no need that you just go and do surgical resection when it was not needed. So, what is the extra advantage of CT scan and why this is the modality of choice here? Because we can post-process the images which we get. We have a raw data with us, and then we have a software in our computers by which we can post-process the images. And in that case, we can have multiplanar reformatting, like you can see the image in the coronal, and then you have maximum intensity projection, especially for the vessels, that will highlight all the vessels, all the structures that are taking up the contrast here. That again, but I'm telling you again and again that this is better be seen in MRCP image or MRI with MIP images, not in CT. But yes, we have a choice of MIP vessels in CT as well. This is basically curved MPR ducts, especially a procedure which we do after getting the raw data for the curved ducts. We have the correction in our software that can help us view the whole of the pancreatic duct, and especially if we are having any sort of artifacts here at the curved margins, we can get rid of that by that software. So these are the few extra advantages of CT which we have. So MRI, basically MRCP, we are interested in MRCP more than MRI. We order dynamic MRI for some patients if we are not happy with the CT results, especially in the periampullary regions, not otherwise. And what is the extra advantage? That MRCP helps us to delineate very nicely whole of the biliary tree along with the gallbladders and the pancreatic duct. Can you see this is dilated tortuous duct with dilatation of the side branches as well. We are happy to have MRCP with us because gastroenterologists use contrast and they do ERCP to highlight the biliary system. Well, we can do without giving contrast to the patient because these are heavily weighted T2 images, and we just can have the beautiful display of the biliary tree, yeah, with the, yeah, yeah. But the best part of it is that we are not giving any contrast to the patient. Because when you do ERCP, first of all, this is invasive, ERCP is invasive procedure, and then you have to put contrast in the system. Yeah, that is for vessels, not for the biliary tree.
The thing is that is why we stopped doing diagnostic ERCP.
Yeah, because MRCP is, I think, the best for me. Yeah. So I'm happy that we are best in some. So these are the basic pathologies which we see in pancreatic imaging. While Saad Bhai, since he asked me to just tell more about the pancreatic tumors on CT, so I'm going to go into detail of the pancreatic tumors. We have benign, primary, endocrine, and metastasis, which you all know better than me. So 75% of the tumors sit in the head areas, 15% in the body and neck, and 10% in the tail. Now this point is important here, that the tumors originating in the distal common bile duct or ampulla may also grow into the pancreatic head, and together with the pancreatic head carcinoma, these tumors are often called periampullary. Being radiologist, this periampullary tumor troubles us the most because the staging, the imaging, is the same for all these three tumors. So we are stuck in this area on CT. So in that case, we order a dynamic MRI or MRCP. Yeah. So these are a few of the primary which have solid and then cystic tumors and metastases, only 5%. So we are lucky to have metastases only 5%. Imaging modalities, as I've told you, we have ultrasound, CT, and MRI, and in pancreatic cancers also, not even in acute and chronic pancreatitis. In pancreatic cancers also, CT is the gold standard for diagnosis. And what matters the most is the staging. Okay. Now this, I think, when you order CT for, especially for the pancreatic lesions, you should write particularly that we want to look into some pancreatic lesions, since we are interested in pancreatic parenchymal abnormality. We would be having a pancreatic or early portal phase. This is taken at 40 seconds after injection of the contrast. In 40 seconds means that the moment you start injecting the patient, it takes 15 to 20 seconds to reach into the aorta, which is ROI, which we set on the monitor, region of interest. After adding 15 seconds from that, when the contrast reaches the ROI, after that 40 seconds will be the pancreatic parenchymal phase. And being gastroenterologist, you should order pancreatic parenchymal phase if you are interested in pancreatic pathology, especially the pancreatic tumors. And obviously 130 mils of the contrast at the flow rate of 3 mils per second, and slice thickness should be kept at 2 to 3 mm, because we can now construct it in 5 mm. The other day Mustafa Bhai was asking me about the slice thickness. So this is the slice thickness which we usually recommend for pancreatic pathology, 2 to 3 mm, but then we can reconstruct it on 5 mm slices. Yeah.
So without contrast, is it very difficult to report on?
Obviously, yes. If normal pancreas, no problem. But yes, if you if you have pathology, you have to give the contrast to the patient, and you should also order pancreatic parenchymal phase. It's actually the late arterial and early portal venous phase. It's 40 seconds when the pancreatic parenchyma is taking up the contrast. Yeah. 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 Late delayed arterial or early portal is same. Yeah. Essentially, when we divide the phases of CT, it's 35 seconds which we call its delayed arterial, but 40 seconds is delayed arterial or early portal venous, because in that phase we start seeing the portal vein and splenic vein and everything, and that is the phase actually when the pancreas is taking up the contrast. So we are interested in that phase. Yeah. And yes, if you are ordering pancreatic parenchymal phase, that CT will be called a triphasic CT, if you are not adding the scout film together. Yeah. So this is the most important slide here, that we should be able to stage the pancreatic tumor accurately on CT, because that is going to decide whether the tumor is resectable or it is not for the surgeon, and that's what the surgeons are interested in to know. Now, this is a simple axial slice taken at the level of the pancreatic comma here, and this is the duodenal bulb. This is D1, and this is D2, which is sweeping across the pancreatic head here, and this is the pancreaticoduodenal groove. The very thin hypoattenuating line here separating the head of the pancreas from the duodenal lumen. This is the pancreaticoduodenal groove. Okay, and this is the head of the pancreas, this is the neck of the pancreas, the body and the tail we will be getting here when we go a single slice or two slice superior to this level, because the body is sitting a little below than the tail of the pancreas. So yeah, this is the portal vein here, this is the splenic vein going towards the spleen, and this is the superior mesenteric artery. Now this relation is very important. The superior mesenteric vein is anterior and towards the right to the superior mesenteric artery. So this, Sadhbhi, especially for you, because you were asking me to tell, yeah. So this is the superior mesenteric artery. This is the whole hypoattenuating rim around the superior mesenteric artery, which is clear and clean of any soft tissue here. so it's clean. This is the superior mesenteric vein, and it is going to form portal vein here. This is the mesenteric root, this is the aorta, and this is the IVC. So this slice you should be knowing very well when we are actually doing the staging of the pancreatic tumors. So when do we call the tumor is resectable on CT, and when we call that it is irresectable? The very important point is peripancreatic end, that the peripancreatic tissue around the pancreas, if I go back on the slide, yes, here. So this is the peripancreatic area, which should be clean of any tumor here. Now, limited in growth in fat or duodenum. I am not sure about duodenum, because when we are doing Whipples, we actually get rid of the duodenum as well. And I'm sorry. Yeah, in 10 minutes, okay. So limited in growth in the fat, which means that the peripancreatic fat which is visible here, if the tumor is involving it, but not much of it, it can be resectable. But if we cannot see any clean plane around the pancreas, the tumor is irresectable. Now, this is a very important point here, that less than 180 degrees vessel contact. What I really mean about that is that this is, if we start here from 12 o'clock and we just go around the vessel and then reach back at the 12 o'clock position, this is the whole circumference 360 degree curve, 360 degree whole around the vessel. Now, less than 180 means going from 12 to 6 or from 6 to 12. If it is less than 180 degree encasement by the soft tissue of rim of the tumor, it is resectable. But once it is more than 180 degrees, it is unresectable. Like here, more than 180 degree vessel contact, that is unresectable. Or you must be knowing that liver and peritoneal mets, the tumor is irresectable now. Yeah, so we have mets, whether in liver or nodes or peritoneum, the tumor becomes irresectable. I just want to elaborate this point here. Fat plane resectable. It's not necessary to have a fat plane around pancreas, because in the patients who are thin and lean, we usually are not getting any fat plane. It doesn't mean that the tumor has infiltrated the fat and now we are not able to see that fat, even in EUS. The other day, I don't remember exactly, there was a comment here that if you are losing the fat plane around the organ, it means it's tumor infiltrated. No. Because in thin patients, most of the times the fat is not there. So if it's not there, it doesn't mean that the tumor has infiltrated and we are not having any fat interface. What important point is here, that if the tumor has invaded the outermost layer of the organ or the vessel, it means that tumor invasion is there. In that case, the tumor becomes irresectable. So we have stages of the tumor, 1 and 2 resectable, 3 or 4 unresectable, 4 is the mets, 3 is the nodal involvement, 1 and 2 is basically confined to the organ. So this is just a pictorial essay. So are you guys interested in TNM? No? Okay. So now this is an important slide, that we can grade the venous encasement and resectability of the tumor on CT. Grade 0 is if we are having a normal fat plane between the tumor and vessel. Grade 1 is loss of the fat plane between tumor and vessel, and if the patient is fat. If the patient is already thin and lean, we are not interested in here. Grade 2 is flattening and or slight irregularity on one side of the vessel when it is less than 180 degree cover wrap. Grade 3 is more than 180 degrees, and grade 4 is at least one major occluded vessel, that we are having a tumor thrombus within the vessel. So grade 0, 1 and 2 are resectable. Grade 3 and 4, obviously they become unresectable. So can you see that, appreciate the vessels here, they are intact. So the tumor here, which is sitting in the head of the pancreas, is resectable because there is no soft tissue wrap around the vessels. Yeah. The anterior and towards the right is SMV. The posterior and towards the left is SMA. Yeah. Now this is the vessel encasement here. This is SMA. And this is the tumors. This is soft attenuating tissue density tumor here, which is wrapping and encasing the SMA. This is again tumor invasion within the lumen of the vessel. Again, just showing you a soft tissue rim around the SMA. The tumor becomes irresectable. Here again, the same story, but of the celiac. So, Sadhvi, do I need to tell everything about pancreatic adenocarcinoma? You were interested in staging of the tumor in there.
The only problem we got stuck is because he has to leave
Yeah.
his flight.
Okay.
So आप अपनी जो भी
So just the nutshell is the CT is the gold standard if you are interested in pancreatic tumor. What message I wanted to convey to you is whenever you ask for CT, especially for the pancreas, do order a pancreatic parenchymal phase at 40 seconds, number one. Number two, CT is used for staging of the tumor before you ask for anything
When
else.
we say pancreatic protocol,
Yeah,
does it take care of that?
yeah, yeah.
So our job is to say pancreatic protocol
Yeah.
and the rest is obviously
Yeah, it's done by the radiologist, yes. So it's neat. Yes, obviously we do inject the contrast with the power injector. Yeah. So thank you. नहीं नहीं वो that will be taken by taken care of by us. Yeah. Yeah.
अवेलेबल ही नहीं है तो वो आप लिखते भी हैं तो वो ऐसी चीज़ हो क्या जाता है नहीं सिंपल एपिटोलॉजी से कितना लिखवाऊंगा नहीं लिखवाने की बात नहीं मैंने पहले ठीक बात है और जो है ही नहीं तो नहीं करेंगे